I'm Dr. Barry. I'm a clinical psychologist, and here we sometimes talk about court and crime or entertainment, or we just have a general mental health topic. And today's topic is going to be on schizophrenia and eye changes. You all asked, so somebody asked me to talk about this research. I was not aware of it. And so it's really important if you're working with a therapist, if you are talking with someone, sometimes you might be aware of something that your therapist isn't even aware of. So you might ask, "Do you know, are you, I just wanted to know if you've seen the new research in schizophrenia and eye movements." And I had not seen this. Really glad that somebody pointed this out, and we are going to talk about it. Welcome to everyone. Sarah, thanks so much for this comment. We talk about so many different things, and I hope the algorithm sends people to the videos that they like because it's not only court, it's not only, mental health education. I try to do a little bit of everything. And so this video is from, let's see, it's from Crash Course, and it's on schizophrenia and dissociative identities, dissociative disorders. Because often when we talk about schizophrenia, sometimes people think because the name means split mind, some people will think that it's talking about multiple personalities, but it's actually talking about split realities. That when individuals who live with schizophrenia have experienced psychosis, either delusions, there are these positive, negative, there are these different symptoms or disorganized symptoms. Those are the three different types of symptoms that they can experience. Um, and positive doesn't mean that it's like a positive experience. And I will break some of that down a little bit more. Please know that all the references, all the resources that I'll talk about, they are all listed down in the description. There are individuals that live with schizophrenia and that do content here on YouTube explaining their diagnosis, talking about things that work for them, that don't work for them, what it's like to live with schizophrenia. And I'm glad that these tools and things are out here and that this condition is more normalized. And what I mean by normalized is just with treatment, individuals can live well with this diagnosis. And and yet individuals can't be and our society has, and people have thoughts about this, but sometimes when the individual isn't on their medication, that can place them at an increased risk for homelessness. It can make it more difficult to maintain employment. It really can escalate things for an individual. Only a small percentage of individuals with diagnoses like schizophrenia end up committing crimes because every now and then we'll see cases where either somebody will try to say that they have a particular diagnosis in order to plead not guilty by reason of insanity. And then some people legit have psychotic disorders. And the name that comes to mind, because she had a recent chance for appeal, is Andrea Yates. Andrea Yates was an individual that unalived her 5 children. And every year, she comes up for potential release from her psychiatric hospital because she was found not guilty by reason of insanity. And she continues to refuse and decline even having a hearing about that because she believes she needs to stay where she's at and continue to receive the resources and tools that are available there. And she's not diagnosed with schizophrenia. I just bring it up because it's a type of psychosis. She likely had some type of postpartum psychosis. And just because a person experiences psychosis does not mean that they have schizophrenia. There are multiple different disorders or conditions where a person can experience hearing things or seeing things. Anyone, if you get really, really scared, anyone can sometimes think they might hear something that might not be there, but it's more of when we're in a fear state, sometimes that can alter our perception and how we hear, how we see things. And it's not that that an individual is necessarily like seeing things. It's that in that increased state, any little thing, any little noise, the brain is trying to make sense of it. And sometimes the brain will inappropriately say, "Oh, somebody's calling your name," or it'll inappropriately ascribe something to it. There can also be delusions, and when I think of delusions, I think of Lori Vallow. She was found to have religious delusions, and that's where an individual believes that they're the Queen of England or that their lawyer is the son of President Joe Biden. Like, there are these beliefs that the individual have that are not connected and based in reality. And if you try to challenge them on it, they often get very, very agitated and upset by it. And with schizophrenia, with psychotic disorders, the neurotransmitter, the little brain chemical that's normally involved, it's normally the dopamine center. And I'm going to pull up the exact research and some exact things that kind of talk about this a little bit more. And so they're often trying to get some balance when somebody is experiencing psychosis. And so um oh, wow. And so Dominique mentioned dating a guy with schizophrenia, didn't realize he was unmedicated until he started drinking again. Wow. He had stopped drinking for a period of time. Wow. And individuals with mental health conditions sometimes use substances to cope. And so I've also seen individuals with schizophrenia sometimes they will have different um, different ways that they communicate or that they might be at risk of abusing certain substances, especially like hallucinogens. Like sometimes because they might be experiencing things that are outside of themselves and that don't feel real, sometimes they might lean into that, or sometimes they might use some other things. And so I just wanted to mention that. Ritz asked to talk about paranoid schizophrenia. So there are different types of schizophrenia, and one type is paranoid. And with the paranoid symptoms, that's where the person thinks that people are out to get them. Maybe now, okay, so the government can listen to people's calls, like that's like a whole like it's Patriot Act, I think. But they truly feel that they're being like followed by the FBI and everyone. And there's a difference between fears of, being followed or fears of persecution that people are out to get them and an individual that truly has experienced trauma. So that's where when we're talking about psychosis, if there's a history of trauma that can make this a little bit more difficult. So if I'm working with an African American male that talks about when they get pulled over by the police, that they start to have some fears. They have, like they have certain fears that come up for them and that they think something might go wrong. For me personally, I wouldn't perceive that as a paranoid thought, that's just kind of based on lived experience and that this individual is not experienced that like within their culture, within what they experience, this is understandable. Now, if I'm working with somebody and they're saying that all these people are always against them, and then sometimes we have to like dig a little deeper. And sometimes individuals end up getting hospitalized. And that's where we really see, oh no, like they really are psychotic. So they think that somebody's trying to poison them, that all of, like they start to have some really erratic behaviors. And so that can be pretty scary for some individuals. Schizophrenia can sometimes come up in childhood. What's a little bit more typical is in adolescence to young adulthood. That's more common for an individual to kind of have a quote unquote normal kind of development. And then at some point, they might start to show signs and symptoms of schizophrenia in maybe high school or maybe in college or in early adulthood. So, only about 1% of the population ends up with a schizophrenia diagnosis, and there's so much stigma connected to this particular diagnosis that people can sometimes have fears or they can have certain preconceived notions about what it's like to talk to or to be around an individual that has schizophrenia. When the symptoms are managed, the individual can often live a productive life depending on the severity and depending on just kind of what's used to manage their symptoms. Some of the antipsychotics, sometimes that's normally the class of medication that's prescribed. Some of them can have some very strong side effects. So a very old antipsychotic is called Haldol. Like that's a very, and I'm not giving like medication advice or anything. We're just talking in general about these things. And but with some medications like a Haldol or something like that, there can be this severe sedating effect, and there can be a fine line between an individual's symptoms being managed and a person possibly being over medicated. So if I'm working with someone that has this diagnosis, and if most of their day they're just kind of staring off into space, sometimes even drooling, if they've kind of lost their personality, they're not interacting, they're not doing the things that they used to enjoy, I would number one screen for, are they experiencing some depression, but then also are their medications at the right point. Some medications can be like once a month in the form of a shot. Some medications are taken daily. Some people are on multiple medications. And so I like to share that information. All right. So, in just kind of getting more of a baseline on schizophrenia, let's see. Let's share this tab. This is from the Mayo Clinic, and um, schizophrenia can be diagnosed. Normally, in my experience, it's normally diagnosed during psychological testing. There can also be certain screenings that can be done. So, if you have a neuropsychological evaluation, sometimes they'll include certain brain scans. Or if you go to a neurologist, sometimes they will do that. As a psychologist, I do psychological testing to help determine, okay, is this major depression with psychotic features? Is this schizoaffective disorder, which is a mix of a mood disorder and schizophrenia that kind of occurs at the same time? Or is this a diagnosis of schizophrenia or some other psychotic disorder? All right. And so with treatment, often the way to help somebody manage their symptoms, because there is no cure for schizophrenia, the goal is to make sure that they're more connected with reality. And I think medication and therapy, making sure that the person is provided with resources and tools. I've worked with some clients that to help them manage, because there might be times when they had some altered sensory experiences, but it wasn't so severe that they were hearing command auditory hallucinations. So, a command auditory hallucination would be hearing a voice telling you to do things, and or like, negative things, this like negative things about themselves, and it's not their voice. So it doesn't sound like them. It often sounds like a stranger or somebody else. We all can talk to ourselves at times, or we can all kind of have an inner dialogue or hear our inner thoughts. That is not what that's not how individuals that I've met with that have described experiencing psychosis. It often sounds like an intrusive other voice that isn't their own. And when I say intrusive is because often it is troubling. But when somebody has lived with the condition for a while, I've also noticed that sometimes once their head is quiet, that can sometimes be a bit concerning, like almost like not losing a friend, but that they might have to get used to not having some of those experiences as well. And so, having a good therapist, having a psychiatrist or psychiatric nurse practitioner, and then making sure that the person has a lot of good services around them. As I mentioned, antipsychotics are often used, especially at lowering the levels of dopamine within the brain. Because often it is too much dopamine that's being created, that's creating some of those altered experiences, either hearing voices, disorganized thoughts and behavior, or inappropriate affect. So those are just some of those symptoms. All right. Because medicines for schizophrenia can cause side effects, there can be an issue with compliance with medication. And so there are second generation antipsychotics. Now, some people are placed on these medications in lower doses to help regulate mood. So sometimes Seroquel, Risperdal, Abilify, or one of these other medications are used just to kind of help stabilize mood. In higher doses, that's when it's often used to help manage psychotic symptoms. And then those first generation antipsychotics are like the Haldol. Those are often the ones that are very, very, very strong. Like I've worked with individuals on some of those. The ones that I've seen prescribed more are some of the second generation antipsychotics. They tend to have, from what I've heard from psychiatrists, that they have less side effects. Versus some of the first generation. Some individuals do need to go on some of these other medications to manage symptoms. It's also very common that sometimes, if an individual is in the midst of a psychotic episode where they are having command auditory hallucinations, or where they're so paranoid that they need psychiatric stabilization, then sometimes hospitalization is required to help safely supervise and then also safely manage what medication changes, what kind of needs to happen with them. I like to avoid inpatient hospitalization when we can. I live in Virginia, and individuals with certain types of insurance, particularly Medicaid, they often have um, home-based support services that are available, where a person can have a crisis counselor, can receive intensive home-based services. But some individuals' needs exceed what a home-based counselor can provide, and they end up needing inpatient stabilization at times. Right. Um, and stress can sometimes impact like the higher stress, sometimes the more psychotic symptoms individual can kind of experience, and then like not sleeping, but sometimes all these things can impact one another, where an individual might have more difficulty sleeping, more difficulty with all these things, which then might increase some of those psychotic symptoms as well. Individual therapy, social skills training, family therapy, and then vocation, rehabilitation, and support. As I mentioned, hospital stays are sometimes recommended. And then I've never referred anyone for ECT, but that is one of the treatments that's listed here. I have referred clients with treatment resistant depression for TMS, transcranial magnetic stimulation. I have referred clients for that. I don't think that works. I don't think they do that with psychosis. I don't believe. I could be wrong, but all right. So let's go on ahead and come over to the eye exam and schizophrenia and the eyes. I'm going to come back to the chat to make sure I didn't lose. Aha. Okay, I'm going to make myself smaller. Sorry about that. So y'all can see this. Um I don't know. So Dominique, let me know which question this was about. Do they use what often? I I have all these links down below. All right, I will come back to the chat later. All right. So can schizophrenia be diagnosed in an eye exam? So just using an eye exam can't diagnose schizophrenia, but we do know that there are specific differences. Individuals with this diagnosis, there are some differences in eye functioning and in some of the structure with the eye. And once again, like this research is very interesting. And thank you again to the individual that asked me to look into it. And so you can't diagnose somebody with schizophrenia just from looking at their eyes. Um, Sometimes individuals with schizophrenia might not realize that they are like staring and like not breaking eye contact, or there might be some behaviors that the individual might engage in, but that's not a specific symptom. And so researchers do think that the eyes may hold a key in early schizophrenia detection. And for one example being small veins in the retina. So there's some well documented scientific data that some people with schizophrenia have different patterns of eye movements. And this research goes all the way back to the 1970s. Emerging trends in research are focused on identifying biomarkers for schizophrenia using eye movement characteristics, retinal changes, and corneal temperature. Cool. Right now, initial research findings have been really intriguing. They have not yet offered a reliable benchmark for making the diagnosis. So there is no eye test for schizophrenia, but we do know that sometimes there are some notable differences once individuals do have a diagnosis, or we may, if an optometrist sees certain things during an eye exam, they might question, is there a family history of psychosis or psychotic disorders? And then just maybe to have somebody be on the lookout and that's where they wouldn't want to scare people, but I think it would be helpful to know, like, hey, you're showing some of the risks factors for possibly experiencing some potential psychosis. And because I would rather know. So if my optometrist saw something, I would rather them say something than to just, to not say anything. That's just what I think. So what are the visual and eye changes that are associated with schizophrenia based on research? And so, whew, y'all, like, so nystagmus, and I have astigmatism, which just means that with light, my eyes do bursts. So I don't like driving at night. And just at night, the eye, like all the lights look so much brighter. I can drive at night if I have to. I get special glasses that kind of help with my stigmatism, but they say nystagmus. And this is an involuntary, repetitive eye movement. The eyes move side to side and up and down or in a circular motion. That's something that's been noticed. Smooth pursuit eye movements. This refers to the tracking movements that eyes make to perceive something in motion. People with schizophrenia may have different patterns of eye movements. When looking at a scene, they tend to make smaller gaze shifts up or movements up and down. All right. And then there is strabismus. Yeah. This occurs when eyes are not looking in the same direction. For example, one eye turns more than the other one, which is sometimes referred as crossed eyes. Impaired visual acuity. People with schizophrenia may have blurred vision. And so just because somebody has these things does not mean that they have schizophrenia. They're just saying, and looking at individuals with this diagnosis, these are some of the eye changes that were noticeable among the majority of participants. And so we were on impaired visual acuity. Often, when patients present with blurred vision, it is related to the medications they are on. The medications can be sedating to the point where the muscles of the eyes don't sync correctly, which that makes sense to me. Increased blink rate. Some studies suggest that people with schizophrenia have an increased blink rate. However, Dr. Murphy suggests that literature was mostly taken from the 1970s. Okay, all right. Um, And then, so just with some of the symptoms of schizophrenia, we talked about those delusions, false beliefs that are not based in reality, hallucinations, seeing or hearing things that don't exist, disorganized thinking or speech, answering questions partially, offering completely unrelated answers. So if we're sitting here talking about cars, all of a sudden, and not in like a squirrel moment, but like, so if I ask, oh, so what'd you do this weekend? And then like the person either just all of a sudden just starts talking about what they had for breakfast that day or something, and not at all like giving me, engaging in the conversation that we were having, or putting together meaningless words. So that can be a bit of a word salad, just putting a bunch of words together. Disorganized or abnormal motor behavior, displaying behavior that isn't focused on a goal, which can include resistance to instructions, inappropriate or bizarre positions, a complete lack of response, or excessive movement, which might possibly be misdiagnosed as another condition if you weren't aware of some of these other symptoms. Reduced ability to function. So the person might struggle with expressing emotions appropriately, or have issues with hygiene. All right. So, what are some of these causes? So, some of these eye changes may be linked to the medications that the individuals are on. Some changes, such as retinal thinning and narrow retinal venules, small veins, have recently been found to be associated with schizophrenia. Because the retina develops from the same tissue as the brain, retinal changes in the eye might mirror some aspects of brain structure and functioning. Dopamine is known to contribute to some symptoms of schizophrenia. Once again, this neurotransmitter plays a functional role in the dark adaptation of the retina, or the retina's ability to adjust to changing light levels. And so some people will talk about certain sensory difficulties or having different issues. Yes. So stay right there. Do you have a question? Can you give me like another 15 minutes? So you can okay, I'll be down in about 15 minutes, okay? All right. I'm gonna come back to the chat. All right. Oh, and so I don't know about Kohlberger. I don't know. I I I get more just general psychopath type vibes. I don't know him. I don't know what he's diagnosed with. I get more just kind of ugh, odd vibes from him. That's just what I think. All right. Is the characteristics of schizophrenia someone who stares without looking away? And so some people just do things. So Ritz, this is a great question. Some people, so sometimes individuals on the autism spectrum might struggle with eye contact. Sometimes this can be cultural. So in some cultures, when somebody's talking to them, they look away, or some people might have just very intense gauge with conversation or communication. And so, for a diagnosis of schizophrenia, there's generally some type of psychosis. All right, delusions. There's some kind of psychosis. All right. Ah, there we go. Lisa. So a lot of the antipsychotics cause weight gain. So especially Abilify, I've had clients gain like 20 to 40 pounds in like a month. And so often their weight does have to be monitored. I have had clients end up with type 2 diabetes, because it's Abilify in particular. Clients have told me it makes them crave carbs. Like they just want carbs. And so and like it just gives them this feeling of hunger. And I've had a lot of clients engage in overeating. Yeah. So Sarah, I've had some clients gain about 70 pounds in like 3 to 4 months. So like that is very, very common. especially for clients that go into residential treatment. So, residential treatment is treatment for about 6 months to a year. I work with a lot of kids and teens. Residential for adults can sometimes be shorter or longer. In my experience with kids and teenagers, it tends to be about 6 months to a year. Almost all of my clients that have ever went to residential, or if I've worked with people coming out of residential, they almost always gain weight because they're often sometimes the placement will place them on, like, no seconds, because at first, they're able to have as much food as they want until it gets to be a safety risk, and then sometimes they put them on certain, restrictions. But, it's my understanding that these medications make people crave, like, all the wrong foods. But then, it might impact their ability to process and manage, their sugars. I do believe, Lisa, I do believe that pre-existing diabetes for somebody with a family history of schizophrenia, because a family history of schizophrenia is going to be one of the most kind of predictive, or a family history of a psychotic disorder. That's going to increase the risk that an individual in the family might develop a some type of psychosis. All right. All right. Lisa, and in inpatient, the food, because I used to work on an inpatient unit, and, both a residential, a long-term residential unit, and then I also worked on a short-term acute unit, and if I ate the food at the hospital every day, I would have gained, just eating normally, because it's normally very, like, fatty, ugh, like, normally the options were very high carb. I would have gained weight just by eating the hospital food. We did have fried fish Fridays, or it was like fried chicken Fridays. I did always get Friday. I always got the Friday meal, but, the food was delicious, but it was not healthy at all. There were yeah, and so, alright, let's see. All right. Yes. So we said diabetes. So risk factors for developing eye changes with schizophrenia. Diabetes is a serious health condition that people with schizophrenia are at a high risk for developing. Because diabetes itself is associated with all sorts of eye problems, patients with schizophrenia need to have regular eye exams to make sure that nothing is missed. In my experience, what I've seen personally is an individual kind of start developing psychotic symptoms, get placed on medication, gain a whole bunch of weight, and then they get diagnosed with type 2 diabetes. That's just been my personal experience with this. All right. Treating the eye-related symptoms of schizophrenia, they have some treatment options here, and then treating schizophrenia in general. So once again, this diagnosis does not have a cure, and people should consider the medical options and then also the non-medication options as well. The medications have side effects such as weight gain, drowsiness, involuntary muscle contractions, dystonia, decreased libido. And then there can be, and so therapies like group sessions, individual counseling can be helpful. And so, outlook for people with schizophrenia, it's this is a diagnosis that's been around for centuries, and in my opinion, there are some other countries that manage this a little bit different, where individuals with this diagnosis are integrated into society, are supported, and it's more of a community aspect. For a lot of people I've worked with, they've kind of felt shunned, where because they might sometimes engage in some strange behaviors, even with the medication. And there can be this isolation that the individual kind of naturally kind of wants to do. Um, and so because things kind of can shift for an individual that ends up with this diagnosis. And so I do think that in community that kind of increases the risk and chances for having some better options. Um, I have this linked as well. This is a website called Hope for Schizophrenia, And they have a bunch of resources for preparing for an episode, episode triggers. So, some triggers are stopping medications, using substances, being under stress or feeling overwhelmed, an unexpected illness or loss of a loved one, or other major life changes can trigger episodes. And they have a worksheet on understanding episodes. And they also have a podcast with real stories of people. And and then they have some tips on managing episodes. And so one of the tips is to work with your treatment team while you're feeling well to create a crisis plan. I really like this one because when the person is stable, creating a plan, identifying their triggers and warning signs, things to do once they recognize these warning signs, a list of emergency contacts, preferences for medication, treatment history, and providers, and then a list of support that can help. And so, y'all know I really like, just sharing resources. And so living with schizophrenia, and it's so interesting that every single one just talks about like it's not going to go away. And, and I think I like that this focuses on hope because sometimes individuals can get hopeless and be at an increased risk for thoughts of unaliving themselves, especially if they think like this is how things are always going to be. And so I like resources like this that give kind of hope to the family, that give hope to the individual that like, hey, like we can set some personal goals, and maybe it's a small step. Maybe it's just if right now, if the individual is newer to the diagnosis, they were maybe in college and now they're back home. Okay, well maybe going back to the college community independently isn't going to work, but the person might be able to take, to maybe get back into one class a semester if that's not going to overwhelm them too much. Or that person might be able to volunteer for the SPCA, or there might be something. Because I do think that people can lose hope when they think like, this is it, like this is all. And if they feel like they've lost hope for all of their dreams and for all of these other things, because if it can be well managed, the individual can live, you know, they can go on to have a um so and happy is hard because I think happiness can sometimes be based on what's happening, and I don't wanna minimize what it's like to live with this condition because there can be some really real limitations or changes that the person has to cope with. But as a therapist, I still wanna partner with my clients to help them find, okay, what's this new goal? How can we change this around? But first validating like where they are and all of those things, and helping them get stable. Those are often kind of the first places that you start, and then kind of looking at, what's the next baby step. All right. And so choosing your goals worksheet, setting goals, your support network. I truly think having a support network is really important. And then they have a treatment options section, long acting injections. The reason why some people choose this is because you don't have to remember to take it every day. And what a long-acting injectable treatment, it gradually releases the medication into the body over a period of time. I know nothing about the side effects, and so an individual would have to talk about that with their provider. Benefits of this include increased adherence, to reduce need for like daily medications. Medication levels stay steady in the blood because medications like Abilify typically require blood draws. For some individuals I've worked with, it's been as frequent as maybe weekly blood draws, not necessarily with Abilify, but with some of the other antipsychotics. For Abilify, it was at least every like 2 to 3 months, or and then if their behavior changed, sometimes we would get their levels checked just to make sure that they were at a therapeutic level, because everybody's body processes medication different, and there was, like, a level that we wanted to get the medication in order for it to be at a therapeutic level, and medication compliance can be a bit of an issue, All right. All right. And so those were the resources and tools that I wanted to share. Ah, nice, Lisa. Peer support counseling has been helpful. Nice, especially while you find a new therapist. Good luck with that search. Um Somebody mentioned that DBT, dialectical behavior therapy, says losing hope to gain radical acceptance is often necessary. So I actively practice radical acceptance. And radical acceptance isn't denying that what I'm going through is hard. It's not denying my experience. It's just admitting that my experience is and that I am. And this is where I am and not fighting reality. Because sometimes people they want to say, "Oh, I'm going to go back to college." Like they just had their first major psychotic episode. Their medications still aren't completely stable. They still have all of these things and so they're not quite ready to go back and live independently. And I do think sometimes the individual needs to be surrounded by love and support and people that care about them and that can kind of keep an eye on things as well. And so I think that can be helpful. Somebody else mentioned feeling like bipolar 1 is more similar to schizophrenia than bipolar 2. So so those are completely different because bipolar disorder is the manic depressive and sometimes bipolar disorder can have psychosis. So, an individual with bipolar disorder can experience psychosis. That's a little bit more common in bipolar 1 than bipolar 2. And bipolar 2 doesn't have mania, it's hypomania. So, the high isn't quite as like high. Sorry, I hit the mic, but yes. And so, but those are two completely mood disorder versus in the psychotic disorder, like in a completely different section. All right. Yes, this is great. What's the difference between an antipsychotic and a mood stabilizer? Not a medical doctor. Okay. That's my first caveat. I'm aware of these medications because I've had individuals that needed a mood stabilizer and were prescribed Abilify, but it was in a lower dose. And so there's a dose, it's my understanding and let me it was my understanding that there's a dosage that kind of helps regulate mood and then there's a dose that kind of helps regulate psychotic symptoms and for a bipolar disorder you want those levels to be in a certain range. For an antipsychotic you want it to kind of be in a certain range as well. Lisa, thank you. So I had these earrings made on Amazon. If I ever find a way to make them and have them available for you all, I will definitely put that out there. I haven't found anything yet, but um, so let me see with bipolar disorder and the neurobipolar disorder. Because I've had some clients that needed a mood stabilizer that were surprised that they were prescribed an antipsychotic. They're like, "I'm not psychotic," but it's like, "Wait a minute." It's like, talk with your prescriber. And dopamine. So bipolar disorder and dopamine. Haha. Dopamine hypothesis with bipolar disorder. So and I think that's where they think that dopamine can impact like those manic those episodes. So everybody's brain is different. And so for some people an increased level of dopamine they might end up developing schizophrenia. For some people, an increased level of dopamine, they might end up developing bipolar disorder. And so, two people can have very similar things happening and have completely different, just because our body chemistry, all of that, our experiences, everything is just so different. And once again, with bipolar disorder, there can be bipolar disorder with psychotic symptoms where a person can get delusional, where they can feel on top of the world. They can feel like, they can like literally fly or something. Like there can be some delusions of grandeur in bipolar 1 that is similar to a delusion, but it's bipolar disorder. It's not schizophrenia. And finding a good doctor to like parse it out because it can be difficult to kind of figure all that out. An individual can also have schizoaffective disorder. And so normally with bipolar disorder, they're going to experience psychosis in those manic states. But if they're not manic, or like if their mood is stabilized, they won't experience psychosis. An individual with schizophrenia might experience depression, might experience, but they're psychotic all the time, no matter what their mood is. Wait a minute. Yes. Well, but there aren't like major. They might not meet criteria for particular mood disorders, but then schizoaffective is both. And I see schizoaffective disorder often diagnosed in long-term care facilities because they're able to kind of monitor them longer to see what's going on and to just kind of rule out, is this what's really going on? And so, all right, great question. Um, all right. So I'm glad you're covering this live. I'm really struggling with your bestie struggling from psychosis. And there might even be some resources on YouTube for how to support a family member or friend that's experiencing psychosis. And sometimes just asking the individual like, "Hey, if you're having a bad day, would you want to just like watch, like, how can I support you?" The biggest thing is to know that it's not your job to fix them, and it's not your job to make sure that they're okay. And then just making sure that you're aware of any safety plan, anything that they maybe shouldn't have access to if they're not in a good space. Yes. All right. And so, another question: how do you find a good doctor or therapist for these conditions? And so, I would want to work with somebody that is skilled and has like a supportive approach with these diagnoses. Because one of the worst things to happen is that a person has a diagnosis and is living with schizophrenia and then feel judged by their therapist, or their therapist not be skilled or not understand how to support them. For some of my clients, once again, if they meet criteria, if they're able to get home-based supports, that's sometimes been like the best thing, because home-based support can help them clean their room. Home-based support can help them, if they're needing to find a new psychiatrist, that sometimes they can do more of that case management work. If I am working with somebody that doesn't have that in place, I will talk with them about options. I will support them as best I can. We will use our sessions to call around to just help them find the right fit. But that is difficult. So what country, so are we talking about in the US? And if it's in the US, what state? So not every state has home-based supports available. I know in my state, Virginia, uh, for individuals with Medicaid, they have access to certain services. For individuals with Anthem, with commercial Anthem, okay, so Washington State, awesome. So, if the individual has Medicaid, they might even have a member services number where they can ask, are there home-based supports available for people that are, to avoid hospitalizations and things like that. So, a lot of the funding for mental health, instead of it going to psychiatric hospitalization, it went to community-based care. So, community-based care, it are like the home-based counselors. So skills support, home-based services like that. Because if a person can be safely stabilized at home and have that crisis support available in their home, they're often going to do better than in an institution. But if an individual needs that safety of 24/7 supervision and the ability to have a psychiatrist that meets with them Monday through Friday, and then there's somebody on call available on weekends as well, just to help monitor everything. Some people need that short-term stabilization. And so um, it's community-based care, so you would search in your area to see if that was available. I've had a lot of clients have success because that home-based person can kind of help with some of the day to day if it's not the right fit. So not every counselor is the right fit. And what I mean by that is if the individual isn't showing up, if they're not, doing their job, like sometimes you have to call the agency and, get a better fit. But I truly appreciate you all. I'm glad that somebody recommended that I even cover this because as I mentioned earlier, I wasn't aware of some of the eye differences. So I'm not an optometrist, but if I have somebody that's experiencing psychosis, just to recommend an updated eye exam and if they're experiencing any sensitivities with especially once they're on medication, just for us to monitor those things as they're kind of just learning to live differently. And so, thank y'all for being here. Saturday, there's going to be a live about generational trauma and parenting. So it is going to be a premiere on Saturday. And if y'all want to watch it together, watch it together. I am going to make it available to members. It's this exact same video. So if people want early access, members will have early access, I believe, because I have to edit the video. So by Thursday, members will have early access. I so appreciate you all, and I will talk about, what my weekend was like when I come back next week. Super excited to share, and I hope you all enjoy the rest of your day. Bye.